Good afternoon, everyone, and welcome to the next in the series of COVID-19 webinars sponsored by the Emergency Preparedness Network. Today, we are going to talk about dealing with social isolation and loneliness among older adults during this pandemic. And we're lucky to have Dr. Alan Abrams as our featured speaker. So every time we do one of these webinars, we have different people. So I'll reintroduce myself. I'm Dr. Charlene Brown, the CEO and founder of CNA Simulations VR. I've been active in the community working in home care and long-term care in Maryland for the last couple of years. And I'm excited to be partnering with MNCHAI, the Maryland National Capital Home Care Association, and the Maryland Department of Health's Office of Preparedness and Response on creating and supporting this webinar series. And that is why we are going to spend some time thanking all of those people. So the Office of Preparedness and Response at the Department of Health had the vision to move this webinar series forward, and we'd like you to join the Emergency Preparedness Network. So if you just go to that website on your screen, you can sign up to join our mailing list anytime. And if you're a Maryland or a DC home care agency and you're not a member of MNCHAI, you are missing out, the Maryland National Capital Home Care Association. So just go to MNCHAI.org and reach out and learn more about the organization, and perhaps it'll be a good fit for you and your agency. And then of course, there's my company, CNA Simulations VR, where we create virtual reality clinical rotations for nursing assistants to help them become certified during the pandemic. All right, next screen. We have Nasin Weisbord and I, who have been working to curate this series of webinars, are thrilled about the upcoming webinar series, and we have a jam-packed November and December. So today, Dr. Abrams, December 2nd, the week after Thanksgiving, we have Dr. Beth Galick, who'll talk about stress management for home care clinicians during COVID. On December 4th, we have Dr. Luke Kalb, who'll talk about mental distress among children needing care during COVID. So this is the one for people working in home care or long-term care of children, but it's also for anybody who's a parent and wants to understand what's going on with mental distress among children. December 10th, the one and only Linda Tadazio is going to talk about post-COVID clinical considerations in the home. And we're having Dr. Abrams come back on December 15th to talk about caring for older adults with COVID. So Linda Tadazio is going to talk about post-COVID clinical considerations, so the life after you've had COVID, and Dr. Abrams will be talking about adults who actively are in the midst of having COVID. Finally, in December 17th, Ama Adepa Grin is coming back. She's a CNA. She's going to talk about caring for the caregiver from her unique perspective as a certified nursing assistant working during the pandemic in home care. Okay, that's what's coming. So stay tuned, and you can, if you have any questions about how to register for these webinars, just reach out to the Emergency Preparedness Network, info at this whole long thing here, mdemergencyprepnetwork.org, or just reply to the invites for this webinar. So Dr. Alan Abrams, way back when, but not that far ago, I'm a physician and I trained in internal medicine at the Cambridge Health Alliance in Massachusetts. And this physician here was one of the attendings who taught me internal medicine. He is a geriatrician with more than 4 decades of experience working on healthcare delivery models for older adults. He's on faculty at Harvard Medical School. He's on the board of directors for Senior Helpers and serves as their main geriatric clinical advisor. But you know, that isn't enough to keep him busy. So he's also the chief medical officer for Perfect Health and has had this phenomenally interesting career, all centered around care for older adults, largely in their homes. So when the pandemic hit, he was tapped by multiple organizations to really help them build a COVID response for the care of older adults in their home. And before that, he was the chief medical officer for Harvard's Beth Israel Deaconess Care Organization. He's the founding medical director of United Health's dual eligible senior care options program. The home care industry has recognized him as Physician of the Year back in 1993. He was the AMDA delegate to the White House a couple of years ago, and He is very well educated with an MPH from Harvard School of Public Health, an MD from NYU, and he also did his internal medicine residency at Cambridge Hospital, followed by a fellowship in geriatrics at Harvard Medical School. So I'm really, really excited that Dr. Abrams agreed to speak with us today. And he has so much experience thinking about and creating solutions for the loneliness and isolation that older adults feel at home, especially now. But before we turn it over to Dr. Abrams, we're going to have a poll. So let's pop this poll up on the screen, Nasim. And we want to understand who's in the audience today. We were excited that we had over 100 people register, and we'd just like to know what your background is that brought you to this webinar. So just take a couple of seconds to see if any of those apply to you. I think that's probably enough time. Okay, so mostly administrators and social workers with some nurses, PT, and a minority of PTOT and CNA GNAs. But we are pleased to have you, and this will help Dr. Abrams as he structures his talk. So without further ado, I'd like to hand this over to Dr. Abrams. If you go ahead and share your screen, the floor is yours.
Thank you, Charlene, and welcome everybody. Let me get I have a couple of slides, but I wanted to kind of say an introduction that I thought it was really great to actually be slotted for a second opportunity a couple of weeks from now before anybody has weighed in or evaluated my first foray here. So hopefully this will meet your needs and be an interesting conversation. I did want to say that we're all learning as we go. This is a completely unexpected and new challenge for lots of us. I mean, when was the last time that we had lockdowns and at a time when people were living as long as they live now, and in congregate settings, getting the kinds of supports that many of you who are here today are providing for them. So this is all new, and it's really an iterative process. One of the things that has come to the fore of the many complications and the many and the many elements that the COVID infection and COVID pandemic has brought is that it's actually raised to a much higher level of notice the whole notion of social isolation in older adults and the impact that social isolation has. And it's not to say that social workers and sociologists had not studied this before, but in the full comprehensive setting of medical care, it really didn't get its rightful place at the table until now. So we're going to spend a part of this time talking about some of the issues that I think are important to review, but actually at the end of the day, I'd really like to have this be much more interactive and to spend a lot of time answering your questions. So let's get started. I think the first thing that I wanted to make sure that we all understood is that social isolation, loneliness, and depression all seem to be almost interchangeable, but they're really not. So I just wanted to make sure that we kind of in our minds were able to separate these issues. So social isolation is actually being separated from other people. And social isolation sometimes results in feelings of loneliness, and social isolation for many people leads them to become depressed. But there are some people who are socially isolated, and that's the way that they live their life, and it hasn't really impacted their function or their being able to be productive or find meaning in their life. So social isolation itself is something that we need to identify, but then we need to look further to see how it's impacting someone's life. Loneliness is something that you can feel even when you're in a room full of people. And I think the most poignant example of that in my life was dropping my daughter off to summer camp for the first time in her life. And for the first couple of days, even though she was surrounded by all of these kids her age and counselors and everything, she kept calling home saying how lonely she was. So obviously she felt that the connection that she had with us and the rest of the family and her other friends and everything was something that created some discomfort and distress for her. And then I want to differentiate it from depression. So many people who are feeling lonely oftentimes wind up having symptoms that puts them over the line and would be characterized as a depression, which is a mental health disorder that is characterized by this down mood. In order for it to be a major depressive episode, it has to last for at least 2 weeks, and it has to result in an impairment in your daily life. So we're going to be talking about all of these 3 labels, and they are interrelated, but they're not necessarily the same. We need to be on the lookout for all 3. The AARP Foundation, actually, I found a little bit of data pre-COVID, had done some survey, and they found that 16% of older adults report feeling lonely, and that was pre-COVID. So, I would say we need to guesstimate that it's 2 or 3 times that during this COVID pandemic, and that 1 out of 3 adults over the age of 45 have report feeling lonely as part of their baseline survey. So, people wanting to connect and feeling like they don't have the connections that they're longing for is something that in and of itself is almost a pandemic, it seems, in adult life. So a couple of things that are important to then, kind of move to is that, so we don't do a very good job, at least in the healthcare system. And I would bet that the social service folks who are on this webinar probably do a much better job, but we don't do a great job of diagnosing any of these 3 problems. We have gotten better at diagnosing depression because of some of the requirements for quality metrics that all of the payers are being held to. But we don't really do a great job at highlighting and diagnosing social isolation as a problem that needs to be solved for certain people that we're caring for, or their feeling of loneliness. And we'll talk about some of the things that we can do to help people who are in those boats. So we're not going to spend a lot of time on how do you manage depression, but we are going to spend a little time talking about social isolation and loneliness, which has been amplified during the COVID period. One thing that's really important is that while we all know that depression has been in evidence-based studies associated with a lot of bad health outcomes, so has social isolation and loneliness. And they've all been linked to negative outcomes in the occurrence of more chronic illnesses and actually increased mortality. social isolation and loneliness itself has also been linked to cognitive decline. And there's, the social isolation itself through an AARP study has been equated in terms of mortality to the equivalent of smoking 15 cigarettes per day. So that's pretty striking. I mean, these are not subtle or easy problems to manage in people's lives. And like I said, we haven't really done a good job of that in the healthcare system, especially in the older adult segment of the healthcare system, until COVID has kind of brought this to the fore. Now, we do have ways of measuring this. And, I put depression first here because this is something that many healthcare providers and healthcare systems and payers are implementing across the board for all people over the age of 65. So, as part of their general assessment on an annual basis or periodically, they're doing a geriatric depression scale, or they do this questionnaire that's called the PHQ-2. And if somebody's positive, they then go ahead, because they're at higher risk for depression, they go ahead and do what is known as the PHQ-9, which is a little bit more in depth to see whether a person has a serious depression or not. There are very few that I'm familiar with measurements of social isolation and loneliness that are kind of standardized assessment tools, but I did find one, the UCLA Loneliness Scale, that measures a person's subjective feelings about whether they're isolated or not, or lonely, which I think is probably not a bad place to start, because really at the end of the day, as I said, talking on the first slide, that social isolation, like for some people, they are alone, but they're not lonely. For other people, they are with people, but they're lonely. So it's kind of an interesting dilemma to kind of tease out. And then there's the Berkman-Symes Social Network Index, which is another measure, which not going to go into a lot of detail on it for two reasons. One is I'm not that familiar with it, but the other is that we don't really want to focus on how you measure this, because, you kind of know in talking to people when they're missing connections and when they're feeling isolated, alone, and moving towards depression. So, in the long list of things that are related to the feeling of isolation, social isolation, there are a number of factors that we need to look at. And so we kind of mentioned the social circle that people have, looking at that network. Living alone puts a person at a much higher risk of feeling isolated and alone. Function is very strongly correlated with feelings of isolation, loss of independence and isolation, and the negative impact of chronic health conditions can cause a person to not be able to engage as much in their social network, or in community-based activities. So, you can read through some of these, but very importantly, at the bottom of this list is COVID. And the COVID virus has kind of added a new twist to all of this. So it's really important to understand and to measure this either in imprecise ways or in more assessment tool kinds of ways for each and every person that we take care of, so that we can try to fix it, because we know that social isolation, loneliness, and depression all lead to worse outcomes from a health and quality of life perspective for older adults. So I wanted to now get to the meat of the matter, really, which is the impact of COVID on loneliness and depression is really, really significant. Obviously, many of you who are in the field of taking care of people in the community, you know that because of COVID-19, that older adults are considered to be in a higher risk for more severe disease. So there's a tremendous amount of fear that they have. So not only do they have fear of getting the disease by staying in touch with the people that give their lives meaning, but they also are afraid of being taken care of by people like us, like all of us, who are trying to come into their homes to combat isolation and loneliness and help them get through their day, because they're afraid that we might be bringing the virus with them. And so, you know, that makes it really, really complicated, because there's a lot of rejection of supportive care, functional assistance, and medical care. And in my practice, we've had a lot of people in assisted living facilities who have been COVID positive. And of course, they're kind of quarantining, and we did the best we could to use telehealth to be able to visit with them, to do the medical surveillance that we want to do. But, you know, at the end of the day, if we needed to get in there to actually assess how they were doing regarding a particular chronic illness like congestive heart failure, or managing their diabetes and their vision because of their diabetes, even drawing bloods, or, you know, taking vital signs on them, there was a lot of responses that were, you know, like, please don't come. We don't need you now. And as a result of that, you know, some people did not get the care that they needed. The other thing too is that the other side of the coin is, because of COVID, if somebody was living in a facility like an ALF, or even in their home, and they did turn positive, that the level of fear and anxiety that they experienced heightened their determination to not be near anybody, because if they were aware of what was going on, they didn't want to give it to anybody else. So that was a factor. And then finally, you know, for those who were at home with cognitive impairments and weren't quite aware of all of this that was going on, you know, their family members were very, very frightened and anxious, and were really questioning in greater detail everything that we were trying to do around their medical care or their functional support. Was it really needed? How do I know that the caregiver or the provider that's coming in is COVID negative? And, you know, show me the test, and, you know, or else you can't come in, because the last thing they wanted to do was to have somebody that they cared deeply about, you know, kind of get seriously ill from COVID. Just an important ramification of the COVID virus itself on people who were alone and had functional impairments is that, in addition to stemming their appetite, you know, they also were less likely to get the supports that they needed for that appetite. And of course, you all know that COVID in many, many people causes a lot of musculoskeletal discomfort, headaches, etc. So they wouldn't eat or drink, and that would increase their risk of falls. And so in many, many ways, they needed even more support from caregivers to be around them, you know, to push the fluids and help them with nutrition, etc. And then another thing that was really, really interesting, I can tell you how we kind of solved it in our practice, is that wearing PPE and coming to somebody's home who is in this more anxious and isolated state, and especially if they had cognitive impairment, increase the level of confusion and increase the level of anxiety and fear when we had donned our personal protective equipment, and they couldn't really tell who we were. It created, more discomfort and I'll say not major paranoia, but some paranoia. And it was really difficult. Now, we learned this in our practice like right away in March and April of last spring. And so what we tried to do is to get everybody on our team that was visiting any of the people that we cared for in their homes to get them really, really big picture IDs so that they could hang it outside of their gear. And the person could actually see who they were behind that mask and hopefully improve their receptivity to that visit by us. So obviously the other thing that we did is we did a lot of telehealth visits, but I will say that, in order to combat loneliness and isolation, keeping people in touch with the people that mean something to them, keeping them in touch with their healthcare providers if they depend on them, to be reassured about how they're doing is really, really important. We actually strongly believe in supervising safe visits. And so, unlike some of the pictures that you've seen where somebody's kind of standing outside the first floor nursing home window to have contact with somebody who's in the nursing home, we actually went a step beyond that and would actually encourage grandchildren not to be that close, but maybe to hug their grandparent on the leg and then move away, both with masks on, or sometimes, to kind of use a blanket that was going to be immediately washed and have the blanket be between two people who were close to one another and wanting to touch. Just along those lines, when we're born, the first sensation that actually is registering fully is the sense of touch. And, we do need to, as infants, be held. And, in psychological places, some people would say that, it helps us feel where we end. We don't have great vision when we're born, and we can't really locate sound that well. Not sure about smell. All I can tell you is none of my kids complained when their diapers were full, but I certainly did. And when we're getting older, actually things go in reverse. And at the end of the day, and especially for people who have dementia, who have visual problems and difficulty hearing, the physical contact is actually so important as a way of helping people feel less anxious and really feel connected and better. One of the other things that we really promote is, especially during this time, is it's so hard for people who are afraid of COVID. And this is not like only for COVID, but it really is important to emphasize these things, that there are people who are losing their sense of who they are, because who they are is really defined by the people that they care about who can come and visit them, the providers that come, and some of the activities that they might engage in with other people. And so, we have felt that it's doubling down on making sure we help people who are older and being, kind of separated by virtue of the fears of COVID, on both the provider side and the patient and family side, to actually start telling their story again and kind of reconfirming who they are, because everybody has a story, and we want to know who they are. We want them to know that by defining that story, it keeps us connected because we really appreciate who they are, kind of in a Mr. Rogers very special way. So with that, I wanted to, I did a video about this very topic over the summer that was funded by the Department of Public Health in Massachusetts and was developed by the Riverside Clinic, which is a behavioral health entity in not-for-profit entity in Massachusetts that provides a lot of behavioral health services across the Commonwealth of Massachusetts. And I wanted to kind of, it's a 4-minute video, so I want to beg your indulgence. And some of what's on there will reiterate some of these points that I've been making. So can we, do I have to stop sharing my screen? There we go. So if we could roll that.
Yes, Nelson's working on that right now.
Okay. And then we'll take questions, we'll have a Q&A after that.
Nelson, I'll go ahead and share my screen.
Hello, my name is Marlene Kenny. I'm a social worker with Riverside Trauma Center based in Needham, Massachusetts. During the pandemic, a period of incredibly high stress for many of us, one group has remained at highest risk. That's older adults. This incredibly important segment of our community is experiencing fear and anxiety. And Dr. Alan Abrams will talk with us about how we can support them and understand what they're going through.
I'm Dr. Alan Abrams. I'm a board-certified geriatrician who's been committed to taking care of vulnerable older adults in their homes for decades. It's been very, very difficult, especially for the more vulnerable older adults who experience a lot of uncertainty, a lot of isolation, which is leading to many of them becoming more depressed as a result. So there are a number of things that we try to do from our practice to help people deal with the fear and anxiety that's amplified during this COVID era. The first thing and the most important thing is to help identify what it is that they're afraid of. Most people who experience an infection with the COVID virus, even in the older adult population, get through it. So I think that there's a lot of reassurance that can be given about just the statistical probability. And that's a very important thing for us to be able to reassure them with repeatedly. Healthcare workers and caregivers that come into some older adults' home to help them on a regular basis, they both are afraid of getting the virus from one another. So we use both telemedicine and we use regular old-fashioned telephone calls to be able to reach out proactively to the people that we are most concerned about and continue to have ongoing conversations with them. In addition to that, a lot of times we actually have to visit them using protective personal equipment. When we have to do that, oftentimes it invokes even more fear. So one of the things that we encourage people to do is to wear their name tag with their picture on it and maybe even have one blown up so that the person can see who they are behind that mask, and it will be reassuring that it is the trusted care provider that they're used to.
So another tip to help people who are experiencing a lot of anxiety at home around the COVID issue is to teach them how to be visited in a safe way by people that are meaningful to them. During the COVID era here, makes it more difficult for older adults who are stuck in their homes and getting isolated to remember that they are a very important person. Everybody has a story to their life, and it's a very important marker of who they are as a person. By having them retell stories, write things down that are historical memories for them is a very important thing for their mental health. I wanted to share with you the story that my mother shared with me when she lived with us during the last 6 years of her life until she was almost 98. During that time, it was not infrequent that she would remind me that she had lost all of her brothers and sisters and many of her nieces and nephews, and that there was actually nobody left to validate her life. This is really, really important that everybody, as they get older, that we continue to honor who they are and who they were and what their story is. If there's one thing that is a takeaway from all of this for any healthcare worker or caregiver caring for an older adult, it's to remember that the older adult is a person with a story. Learn what that story is and celebrate it. By doing that, you may learn a lot about life and you'll be a more effective provider.
Okay.
So of course I hate seeing myself like that again, but nevertheless, I think it kind of, I wanted to show that to kind of underscore some of the important points that I was trying to make during the earlier part of the conversation. And I wanted to leave time to have, a significant question and answer period or have people make comments so that you can share your experiences during this unusual and unique time. So would you like people to put them in the chat or be recognized in some way?
Yes, if you have questions for Dr. Abrams or comments, just go ahead and put them in the Q&A icon at the bottom of your screen on the far right of the bottom of your Zoom screen. It may be that your talk was so insightful and illuminating that no room for questions. I mean, have any of you seen this challenge of isolation and loneliness among your clients? We have our first question. Is video available? Yes, we're recording the session, and the recording of this presentation will be available on the Maryland Emergency Preparedness Network website, and we'll share that link with all of the participants. Great, one question down. Other questions?
And if they were referring to the video that Dr. Abrams just shared, we can send that link as well.
Oh, absolutely. Yes. Thank you. You're welcome. Other thoughts, questions? Here we have one. In our practice, we have noticed acceleration in dementia. Yes, that does make sense. Dr. Abrams, do you find that the isolation of COVID is leading to worsening of dementia among older adults?
Yeah, well, actually there, not to get too evidence-based about it, I mean, basically the answer is yes, that there actually is an association with the development of cognitive impairment with isolation and loneliness. And so, if there's anything that could be preventative, it would be to try to break the cycle of isolation and loneliness. And as I was saying, it's really thinking about, on the very human level for each individual person, how can we get them connected to things that are meaningful to them which will reduce their anxiety, reduce their tendency towards, moving across that spectrum into a depressive episode, and help maintain their vitality and alertness and cognitive sharpness. So, all of these things, I'm sure, I did want to say as a disclaimer, I am not a psychologist, a psychiatrist, I'm a geriatrician, but we do take care of the whole person. So, these aspects of things are just as important as getting, laboratory data on what their kidney function is from the point of view of our team and the work that we do.
Dr. Abrams, we have 4 questions that have come in that period. The first one is from Catherine. I work with a hospice agency and help on the bereavement support side of our services. And yes, she's seeing grief exacerbated, widows and widowers especially.
Yeah, I think that, one of the things that is really, really difficult about this virus and this period of time is that, people can really take a turn for the worse. They could get the virus, they can take a turn for the worse, like very, very quickly, especially that kind of has been repeated in the older population, especially people who have chronic illnesses and are older. And I think that it is a real challenge to, be able to help support people going through a bereavement process, because it comes on rather suddenly. On the other hand, I would say that whatever we do to help people, which I'm not sure that the medical side of the system really, I'm actually going to say it a different way. The medical side of the system is not really good at helping people with grief. I don't think they really understand it. I don't think they understand how people go through the different phases of grief and how they come out on the other end. And when grief becomes a pathological condition that actually needs more serious, kind of medical psychiatric treatment, I just don't think they're very good at it. But I think all of the things that we try to do to help people is really important. And I just wanted to make one other comment to the person who asked that question, is that, I think anticipatory grief is kind of a term. I don't know if that's a term that other people have used, but, I would say that one thing that our society as a whole is not really great about is that people understanding that life is not forever and helping us work, spiritually and philosophically to be able to kind of accept, the path that we're on is an important anticipatory kind of grief support that I think more creative people than I really can work on. And it's even more important, I think, during this period of time where, somebody can catch the COVID virus and then, take a turn for the worse, while otherwise they were doing really great, just a few days ago. So hope that's helpful.
Dr. Abrams, we have a couple of questions that are related to each other, and so I'm going to combine them. So we have, we have some comments that underscore the importance of the power of listening. And then there's some questions about connecting with patients in the context of the pandemic. So first, do you really think phone calls are nearly as effective as face-to-face visits? And second, for some, it's been very difficult to connect with patients when required to wear masks and gloves. During the video, some caregivers were holding people's hands. Do you think there's a difference in skin-to-skin touch, or would it be better to use gloves, to not use gloves for a brief period and then immediately use Purell and wash, put your gloves back on? This idea of how to communicate with older adults while wearing PPE is challenging. And so if you could talk to that, as well as the power or lack of power of phone calls as a substitute.
Mm-hmm. So I would say telephone calls are not as good as face-to-face meetings. I think that, but they are, you know, kind of a regular part of almost every adult's life. So it's a continuation of something that has been a way that they have connected to people. And so, you know, we try to make proactive phone calls to people, especially the ones who don't have good social supports themselves naturally, and, you know, get friendly with them, and try to be as close to being part of their network and family as possible, in spite of the fact that we're the healthcare providers. And we do, like I said, proactive telephone calls. We did find that our providers, which would be the people who do the face-to-face visits, the social workers are probably in third place because they do a lot of assessments on the phone anyway, but the RN care managers that we have and the nurse practitioners and physicians, that they actually found that by early June, that they really needed to get out and see people face to face, even though there were, you know, risks to doing that. They actually started doing it. So that, you know, I think it's second best, but I think it's better than not connecting. And then the second part of the question was around, you know, do you take the chance of removing PPE in order to really, really touch people? You know, I think that the public health person in me would say, like, no, you really can't do that. But I would say that probably for a lot of people, you know, being able to touch them, even with gloves on, is probably beneficial. And, you know, they feel the warmth through the gloves and they can actually feel the touch through the gloves. So I would say, you know, only in the most extreme of circumstances would I ever, you know, kind of think about doing that without gloves on. I can't imagine that I would ever recommend it to somebody, because it's really not safe.
I concur. And so we have a question that's also related. The difficulty of talking to older adults who have hearing deficits while wearing a mask. Do you have any, you know, any tips beyond speaking slowly and loudly? Because they don't have visual cues, it can be difficult.
So if you can bring with you a little amplifier that you can kind of connect up to their ears, kind of like these things that I'm wearing, but they're connected to a little amplifier box, you can probably, without shouting at them from behind your mask, help them hear what you're saying better. I don't know whether, you know, you could probably get that to work in the other direction as well, if need be. So I hope that helps. We do have, I know one of our providers actually does bring one of those sound amplifiers. Little, it's like less than the size of a cigarette box, a pack, and runs on AAA batteries.
Okay. There are two related questions from Marianne and Lynn. Marianne's noticed a functional decline in clients as well as feelings of loneliness, sadness, and depression. They're using tech to see their clients, phone calls, cards in the mail, window visits, and they're really searching for ways to stay connected. At the same time, Lynn, who works in hospice, are saying that while patients and families regularly talk about the stress of COVID isolation and fear of catching the virus, a few of the families have said they think the isolation of COVID has contributed to the patient's rapid cognitive decline since March. And so we have two questions that are both about cognitive decline and searching for new ways to stay connected.
You know, these are really, really challenging situations for sure. You know, I would say to the first element of the question, that, you know, to let us not forget that older adults who, especially those that are not totally functionally independent, while they're kind of isolated and lonely, that they very likely are not eating and drinking as well as they should. And of course, that's going to make them feel even worse. And it also, so it's really important to be encouraging them from a nutritional perspective to kind of, and help them get that nutritional resource every day into them. And of course, you know, being able to have a meal with somebody is such an incredible connecting activity that if they can do that, even at a social distance with somebody that comes into their home to help them with eating and drinking and so forth, that would be maybe something to add to everything else that you're trying to do. The other part of the question had to do with, you know, people being more cognitively impaired as they get more isolated, and the decline being more accelerated by the fact that they're isolated either by virtue of having virus or by virtue of trying to prevent getting virus. And in both cases, I would say part A is the nutritional message that I gave, but part B is doing all these things that you can think of. And I bet there are a lot of people out there that are a lot more creative than I am, that can think about how to continue to help people have meaning in their life, even while they're going through this episode of time. And I just want to say on that score, so this is the way that I think about meaning in people's lives. So it's kind of simplistic, but I kind of think of it as that there are basically three different elements that give most people meaning in their life. And the different buckets, you know, people take from the different buckets in different amounts at different periods of time, but they are spirituality, which is not necessarily religion, but it's just spirituality, having a relationship with a, you know, a higher being, a greater being, in their own way. It could be, you know, through a religious faith. The second is productivity. So actually doing things that are productive, making things, knitting things, giving to other people, helping others in certain way, shape, or form from their isolated, you know, quarantine at home. So that's a second thing. And then a third one, in addition to spirituality and productivity, is relationships. And, you know, that is kind of people, there are some people who get a tremendous amount of meaning by having relationships, and encouraging those who can to actually reach out and have relationships from wherever they are to the people. And it doesn't have to be just a family. It doesn't have to be an obligatory, you know, calling a family member or something like that. It's the people who are really important to them and staying in touch. And these days with iPads and FaceTime and other kinds of ways of actually visualizing people, it can help to kind of bridge the gap a little bit. So I just think of things in those three buckets and then try to find the menu for that person at that time, knowing that it's going to change from week to week for them, or even day to day. Some people hour to hour, who knows?
That's actually really great. Catherine wanted you to know that she totally agrees about bereavement and grief being a challenge to many people. And she just wants to thank you for the care you provide and your amazing presentation.
Oh, thank you.
We had a question that you've been answering throughout in pieces, but we have an explicit question about any final thoughts and activities that you haven't already discussed that you could suggest to be offered to older clients virtually. And we have a suggestion from Lynn, who said that they use video calls when possible, such as, you know, 8x8 or connect on FaceTime. So we have video calls as one, but are there any activities that you haven't already discussed that you'd want to offer as a resource for some of the people on the call?
Let me, as I said, you all are more creative than I am. I just keep trying to think of how to reach out to people to help keep them connected. I don't have a good spontaneous answer for that one. But there's, another way of keeping connected, for example, would to have, a lot of people from the generation that we're talking about, they're not used to text messaging and Instagram and those kinds of things. So actually writing letters is a good way of communicating, and it's kind of a lost art.
That's actually a really thoughtful idea. Okay, thank you, Dr. Abrams, says another person who asked a question. Okay. And I thank you, Dr. Abrams, for your excellent presentation, for sharing your insights and experience with the people who joined us today. And as always, I continue to learn from you decades later. And I'm going to switch gears and just take another moment to thank, stay tuned. Oh goodness. We are gonna thank, of course, EPN, the Maryland Department of Health Office of Preparedness and Response, MNCHAI, and CNA Simulations VR. If you want to get in touch with anyone, the contact addresses are on the screen. And more than anything, we thank you, the audience, for participating and creating the space for us to have this important discussion about loneliness and social isolation that is really crippling the older adults that we care about during the COVID-19 pandemic. So thank you for joining us, and you have a wonderful rest of your week. Please stay safe. Take care.
Thanks, Charlene. Thanks, everybody. Bye-bye.
Thank you, Dr. Abrams.